Hello, everyone, and welcome to our November edition of Pharmacy Essential Updates. My name is Sarah Clocker, and I am an editor here at Pharmacist Letter, and I'll be doing today's presentation. Before we get to today's content, here are some CE instructions and reminders. The November Pharmacy Essential Updates is worth 1 hour of live CE credit. Credit will be awarded to participants who attend the webinar and complete the online evaluation. Please be aware that the November Pharmacy Essential Updates is being offered multiple times. And you might have registered for or even attended more than one offering, but you can only get credit for the November Essentials webinar a single time. The quiz password for today's presentation is 6636. You'll see it up on your screen. You'll need this quiz password to get credit when you complete your quiz. Again, today's quiz password is 6636. Please note that in order to get credit for today's session, you must have pre-registered for the course and also be logged in with your specific login, so we have a record of your attendance. Please also keep in mind that you'll need to complete the course quiz within 30 days of today's presentation. And now let's get into our content for today's program. I'm going to kick things off by answering some questions that we've been getting about giving multiple vaccines to patients. Then I'm going to talk about the treatment of COVID-19 and influenza. Then I'll be spending some time clarifying opioid allergies and intolerances. And then I'll wrap up with our natural medicine spotlight on echinacea. So remember to send in your questions and comments throughout the program by using the Ask a Question tab. This is also where you can participate and answer any questions that we may ask you. We have editors on staff looking out for your feedback. And then at the end, we'll talk about some of your questions during our Q&A session. Let's jump right into our first topic and answer many of your questions from the last couple of months on giving multiple vaccinations simultaneously or on the same day. And our article says, patients will ask you about getting multiple vaccines at the same time with COVID-19, flu, and RSV immunizations in full swing. And this is also in addition to all the other routine vaccines, such as pneumococcal or zoster, or the many childhood vaccines that are necessary. So this is why we're getting so many questions from patients and colleagues and family and friends about giving vaccines during the same visit. So we can continue to listen for concerns and share the latest facts as we know them. Which it can be hard to sift through all of the headlines and social media posts to find trustworthy resources. But it's important that we acknowledge the conflicting data out there with the newer vaccines, with COVID-19 and RSV especially. They are making headlines, so it's good to acknowledge that. And then explain that the latest CDC recommendation is that COVID-19, flu, and RSV vaccines can be given at the same time. It's also important to share that safety monitoring is ongoing with each vaccine and also with the co-administration of vaccines. Safety signals do continue to be evaluated when they are surfacing. So keep in mind that technically there's no max number of vaccines you can give at one visit. Continue to use shared decision-making and consider the patient risks and the likelihood of a return visit to avoid that missed opportunity. So remind patients that getting multiple vaccines at the same visit doesn't generally impact efficacy. It may impact the number of antibodies created, but we don't necessarily know that this decreases vaccine efficacy in most cases. And also, it may be helpful to remind patients that children often get many vaccines at the same time. So let's just review a few reminders when giving more than one vaccine at the same visit. We can try to use different limbs or different arms, especially with vaccines that might cause local reactions. Some folks really have a bad reaction with COVID-19, a local reaction, or Tdap is another example. And then keep in mind that if you're going to give vaccines in the same arm, just to separate them by at least an inch, and that's so you are able to tell, which vaccine is causing a reaction if there is one that does occur, just to know for future vaccinations. Also, try to inject the most painful vaccine last in an arm by itself if possible. Some examples here are the HPV vaccine or the MMR. Those tend to be a bit more painful. And it may also be helpful to give patients getting multiple vaccines a vaccine map. And this is just writing down which location each vaccine was given in the event there is a local reaction. And then, even if patients beg you, keep in mind different vaccines should not be combined in a single syringe. But it is a good idea to give FDA approved combo vaccines if possible. So, for instance, pick the combo Hep A B series Twinrix for eligible adults who need both. It's also important to remember you can give live and inactivated vaccines at the same visit. But if patients opt to get vaccines at different visits, tell them to come back at any time for inactivated vaccines. But you do need to separate live vaccines by at least 4 weeks if they're not given during the same visit. So that's the FluMist, MMR, varicella, and just try to keep a callback list or make reminder calls to ensure that patients do get their follow-up vaccines. One of the concerns of getting multiple vaccines is that folks think side effects will be additive or exponentially worse, depending on the number they're getting. But generally, that's not the case. Some evidence shows that people are only slightly more likely to experience side effects, such as injection site pain, a headache, or fever, if they get multiple vaccines at once. So if patients do get side effects, they are generally the same whether they get one vaccine or more than one. But let patients know to expect that arm soreness or pain for a couple of days after any intramuscular vaccine. Some tips to provide them are, to recommend using the arm, not resting it after vaccination. They can also apply a cool compress or washcloth for pain if needed. And we also want to tell patients that flu-like symptoms, aches, fever, are possible post-vaccination, but these shouldn't be confused with flu itself or COVID itself, the illness that the vaccine is trying to prevent. It may be helpful for some to reinforce that these inactivated vaccines can't cause the disease they're trying to prevent. And then continue to be prepared for the rare anaphylaxis reaction to any vaccine. We do get a lot of questions about taking analgesics, such as acetaminophen or NSAIDs. There is some mixed evidence in kids that pre-injection analgesics might decrease the immune response, but there aren't good data on whether they reduce vaccine efficacy. So I generally don't recommend using analgesics as a pre-med before vaccination. But if patients show up and have already taken, ibuprofen or acetaminophen, there's no need to defer the vaccination. And then save acetaminophen or NSAIDs for after the vaccination if needed. So let's just review some practice pearls before we jump on to the next topic. We want to just help patients catch up on other necessary vaccines. So when they're in for their, flu vaccine, we can just double check things, see if they need a Tdap or pneumococcal. Also, we can keep a callback list or make reminder calls if needed. We can also continue to work as a team to prevent vaccine errors. So for example, here are just a few tips, to consider to help prevent storage and preparation errors. Keep in mind to store vaccines in separate bins, on different shelves with eye-catching labels. And as a best practice, label syringes as you draw them up, keep doses separate, consider using pre-printed labels to improve efficiency. Those are just some tips there. And then also when giving vaccines, bring only the needed vaccines to the administration area, one patient at a time. And then ask open-ended questions to confirm you have the right patient, the right vaccine, and show the patient the labeled syringe before giving the injection. These tips can go a long way on a busy day. And then use our resource, Vaccine Administration Strategies. We give tips and a checklist of strategies to help minimize patient anxiety, make the injections less painful, and some tips to prevent vaccine injuries. We also have our Immunization Resource Hub, which is easily accessible from the Browse drop down menu on the main homepage. Use these recommendations, clinical resources, and other guidance to help stay on top of the latest immunization recommendations. You'll see our latest immunization articles, immunization charts, and clinical resources, and then CE courses too, including any immunization related podcasts that we have. So it's a great resource to keep handy. Now we're going to switch gears and look at antivirals for outpatient treatment of influenza and COVID 19. And we're writing about this because we're getting questions about how to treat COVID 19 and influenza. We just spent some time discussing that the best bet against these respiratory viruses is prevention and getting vaccinations. But as we know, some patients will still get sick with the flu and or COVID and need treatment. And as our article says, don't feel compelled to recommend an antiviral for COVID 19 or flu in most healthy patients. So let's review what COVID 19 and flu treatment options we have and when to recommend them. To begin our discussion about COVID 19 antivirals, let's go through a case. Jane is a 63-year-old patient who's come down with COVID. She says she feels awful with fever, aches, fatigue, cough for the past day or two. She just went to see her prescriber and is now coming to get this prescription filled. You take a look at her profile and see if she takes cetirizine OTC for allergies, lisinopril for blood pressure, metformin for diabetes, and also takes simvastatin for her high cholesterol. So what should we consider to determine if this prescription is appropriate? What other questions do you have about Jane's health? We'd love to know what's going through your mind when you get prescriptions for COVID 19 antivirals. So go ahead and send us in your thoughts in the chat box, and we'll come back to this case a little later. And let's first take a look at how the antivirals for COVID 19 stack up. This slide compares the available antivirals for outpatient COVID 19 treatment. We have remdesivir or Veklury on the left for patients 28 days of age and up. It's often not practical since it's a 30 to 120 minute infusion, and it's given for 3 consecutive days. But remdesivir can be started within 7 days of symptoms and has very few interactions. In the middle in orange, we have oral Paxlovid or nirmatrelvir ritonavir for patients aged 12 and up. It's given twice daily for 5 days, has many interactions, and needs dose adjustments for kidney impairment. And we'll review this in a bit more detail in a few minutes. And then on the right in blue, we have molnupiravir or Lagevrio. It's for patients age 18 and up, but it's not as effective as remdesivir or Paxlovid and should be reserved for when these other options can't be used. And both of these oral options should be started within 5 days of symptoms. So which patients with COVID-19 should we treat? We'd recommend treatment for patients at high risk of developing severe COVID-19, even if their symptoms are mild. So some of the risk factors for more severe COVID-19 include underlying medical conditions such as asthma or diabetes, or patients taking immunosuppressants. Age is also a risk factor, as risk of death increases with age. So starting around age 50 and jumping again at 65, and then each decade, the risk increases exponentially. And then in most of the cases, which med would we recommend? We'd usually recommend Paxlovid or Nirmatrelvir ritonavir. This still seems effective at preventing hospitalization and death, even with circulating variants. So let's just review some of these specific considerations for Paxlovid, since this is usually what we're seeing in practice. We want to know if the patient has had COVID for 5 days or less. If we're kind of beyond that period, it might be too late to start it to see any benefit. And if possible, we want to know if the patient's liver and kidney function are appropriate. For example, we wouldn't want to use Paxlovid for end-stage liver disease, or if the patient's estimated GFR is under 30 mils per minute per 1.73 meters squared, the patient doesn't qualify for Paxlovid use. So those are just some considerations. And then we'd also watch for that laundry list of drug interactions that we can see, since Paxlovid contains the strong CYP3A4 inhibitor ritonavir. So since Nirmatrelvir ritonavir is only a short-term med, we can usually manage the drug interactions for the duration the patient is on this med. But there are a few interactions to keep top of mind where we shouldn't combine certain meds with Paxlovid. So, for example, if a patient is on phenytoin or salmeterol, we would want to recommend a different COVID-19 treatment in these cases. In most other cases, it may be okay to start the antiviral and manage the interacting drug. And, one example that we commonly see is statins. In most cases, we should hold lovastatin or simvastatin for at least 12 hours before starting Paxlovid, during treatment, and for at least 3 days, preferably 5 days after treatment completion. So that's just one example of how we can just hold the statin. And then it may be helpful to know what common meds are okay to use with Paxlovid, such as famotidine, metformin, citalopram. And then also keep in mind that there are some great drug interaction resources, such as the COVID-19 druginteractions.org interactions checker from the University of Liverpool, or the NIH website has very thorough drug interaction information. And these resources help provide the specifics and offer management strategies. And before we move on, here's just a quick review of Paxlovid dosing. Most patients will take 3 tabs twice daily for 5 days. So it's 2 of the 150 milligram Nirmatrelvir tabs with 1 ritonavir 100 milligram tablet. But patients with reduced kidney function, so if the eGFR is 30 to 59 mils per minute, patients should just get 1 of the Nirmatrelvir tablets twice daily instead of 2 tablets twice daily. But the ritonavir dose doesn't change. Keep in mind, you do not have to obtain an eGFR. Treat Paxlovid as you would any other prescription. So let's go back to Jane and think about whether an antiviral makes sense for her. We said that Jane is 63 and has diabetes, both of which can put her at higher risk of developing severe COVID. And she's had symptoms for the past day or two. So she's under that 5-day mark for starting an oral antiviral. But based on what we know, we can consider treatment with an antiviral for COVID-19 for Jane. And she has a prescription for Paxlovid, the 300, 100 milligram dose pack to take twice daily. And looking at her med list, which many of you pointed out, she is on simvastatin, so that's a good catch. We can still use the Paxlovid, but we should hold the simvastatin dose. And after inquiring, she's never had any kidney or liver problems, so the dosing's likely okay and doesn't need adjusted. So thank you guys for chatting in some good questions and considerations for Jane. Be sure to check out our algorithm, outpatient COVID-19 treatment options, to help recommend a med for COVID-19 treatment if needed. So let's go through a case now to begin our discussion about flu antivirals. Ethan is a 43-year-old patient who's come down with the flu. He says he also feels awful with fever, aches, and cough for the past day. He just went to his prescriber and is now coming to get this prescription filled. You take a look at his profile and see he takes hydrochlorothiazide for high blood pressure and metformin for diabetes and a multivitamin. So what should we consider to determine if this prescription is appropriate? So go ahead and send in your thoughts, and we'll come back to this case later. And then we'll take a look at how the antivirals for flu stack up. This chart compares the oral antivirals we're used to dispensing for flu treatment side by side. We have oseltamivir or Tamiflu on the left and baloxavir or Xofluza on the right. And in terms of dosing, we know oseltamivir is used twice daily for 5 days to treat the flu, but baloxavir is just one oral dose and is based on patient's weight. So one dose can be appealing for some patients. They also differ in their approved age ranges for treatment. So oseltamivir can be used in patients 2 weeks and older, but baloxavir is for patients 5 years and older. So these are just some differences to keep in mind when suggesting an antiviral. Also keep in mind that these antivirals work best when started within 2 days of getting symptoms. Antiviral drugs can lessen fever and other symptoms and shorten the time you're sick by about a day. And the goal is to prevent the serious flu complications like pneumonia when the treatment is started earlier. And here are a few other differences. Baloxavir tends to cause less GI upset than oseltamivir. And then both of these meds can be taken with or without food, but taking them with food may improve that GI tolerability some. And then just caution patients that baloxavir shouldn't be taken at the same time as products containing calcium. So this also includes dairy, iron, magnesium, selenium, or zinc. These can decrease baloxavir absorption and may not work as well. And then kidney function may also impact dosing of these meds. And then we just don't have as much data with baloxavir in severe kidney impairment. So, which patients with flu should get treatment? There are some patient groups recommended to receive a flu antiviral for treatment to reduce those complications. And the people who fit into this bucket include hospitalized patients, severely ill patients. So these are patients with pneumonia or asthma or COPD exacerbation. And then most high-risk outpatients. So those are patients who are immunocompromised or those who are pregnant. And then for these patients, we should stick with oseltamivir for now to treat the flu. We just don't have evidence with baloxavir in these situations. But for other outpatients with non-severe flu, but with risk factors, such as diabetes or heart disease, data suggests baloxavir works as well as oseltamivir. So in these patients, we can consider either treatment option, baloxavir or oseltamivir. It might come down to what you have available. So just looking back at Ethan, thinking about whether an antiviral makes sense for him, we did say he has diabetes, so that might put him at a higher risk of complications. So based on that, we can consider baloxavir or oseltamivir as treatment. His prescription here is for oseltamivir, which seems appropriate. But if there are supply issues with oseltamivir, or if Ethan has adherence concerns, knowing he won't be able to take all the doses, baloxavir is an option for him if we need to change that. And here are some other considerations when we're thinking antivirals for flu treatment. For any patient, we do not want to recommend combining oseltamivir with baloxavir. This doesn't seem to be beneficial. On the other hand, it is okay for a patient who has both flu and COVID-19 to take an antiviral for flu with an antiviral for COVID, like Paxlovid. There aren't any drug interactions of concern when combining these antivirals. So that's an important thing to note. And then It's also important to remind patients if they ask, antivirals for flu don't treat COVID, and antivirals for COVID don't treat flu. Even though some of the symptoms do overlap, it's different viruses. And then we can review some practice pearls before we move on. When we see prescriptions for antivirals for flu or COVID-19, we do want to just verify that we have a current and complete med profile, including OTCs and supplements, to help identify possible interactions. And also just keep an eye on inventory of antivirals and watch for any payer issues. As we chatted about earlier, antivirals work best when started as soon as possible. So orals for COVID-19 should ideally be started within 5 days, and then the flu antivirals ideally within 2 days. So it's important to keep those prescriptions moving when you can. And also continue to recommend vaccination and other prevention strategies. Just reminders to share with your family, your staff, friends, staying home when sick, covering coughs and sneezing, washing hands. These are just good reminders this time of the year. We also have a great chart called Antivirals for Influenza, and it provides more guidance on the use of antivirals for treatment and prevention, as well as all of the available antivirals, including place and therapy, dose, and duration. So be sure to check this out if you have questions about other options. Now let's shift our focus to an issue that comes up often in pharmacies, and that's about allergy alerts. And let's clarify how to handle opioid allergies and intolerances when those alerts do pop up. As our article on this topic says, opioid allergy alerts often create a conundrum, since most reactions are documented incorrectly or incompletely. And that's a big problem because we know this can lead to alert fatigue, where we do become desensitized to these types of safety alerts. It can also lead to confusion about whether a patient can actually take an opioid or which one. So let's chat a little bit about how this might play out in practice. You might have a patient with a new prescription for oxycodone, and as you're in the process of filling the prescription, an allergy alert pops up that the patient is allergic to morphine. So what do you do next in this situation? Feel free to use the Ask a Question tab to send us in your thoughts and let us know what you would do as your next step. And then let's take a step back and think about the types of reactions that can occur with opioids, because that's really going to help determine what we should do in a case like this, where you will see this generic allergy alert pop up. So to put things in perspective, I think we can start off by taking reassurance in the fact that less than 2% of opioid reactions are a true allergy. So the majority are not a true allergy. And of course, with any intolerance or allergy, it's always just a good opportunity to reconsider and reevaluate. We can use any of these opioid alerts just as an opportunity to ensure patients might be using non-drug measures or non-opioid alternatives, such as NSAIDs or acetaminophen. And this is especially because of all the concerns that we know come with opioids. But then there are those instances when an opioid may be needed. And so when that is necessary and this allergy alert does pop up, we can continue to use a practical approach to handle those allergy alerts, starting with gathering details about the reaction, assessing the patient's reaction type and individual risk based on those details, and then evaluating options for treatment and next steps. So let's go through these steps. Gathering details is critical. We want to be sure to document the specific med the patient had a reaction to rather than just listing opioids. We also want to ask what the reaction was, how the reaction was managed. It can be also helpful to ask how quickly the reaction happened. That might be another key component to know how severe things were. And then to find out if the patient's taken any other opioids since the reaction, how those were tolerated. And also, it might be helpful to ask if they've ever had the same reaction with a different drug that just might give you insight into their risk of allergic reactions to meds in general. And it's definitely key once you gather these specific details to document that in your system clearly. So, in terms of the types of opioid reactions a patient may have, we can separate them into two broad groups: those that are non allergic and aren't true allergies in blue, which could either be adverse effects or what sometimes is called a pseudo allergy. And then the other group in purple are the opioid reactions that are a true allergy or an immune mediated reaction. So let's unpack each of these to determine tips for identifying them and also how to manage them. So if we start with that bucket of non-allergic reactions and look first at those adverse effects, we can keep in mind that opioids have many common adverse effects like nausea, stomach upset, constipation, drowsiness, dizziness. And again, these are not allergies. And often, once we start talking with patients about the reaction they actually had to the opioid, after we get an interaction alert like the one we saw earlier, it becomes clear that the quote unquote allergy is only a side effect such as stomach upset. So in these cases, the patient may in fact be able to take the med. They just may need to take it with food if they have stomach upset, for example, rather than needing to avoid the drug. So that could be one scenario with our allergy alert. And then in these cases, when it is an adverse effect, if your system allows it, we would want to label that non-allergic reaction as an intolerance instead of an allergy, or possibly add a profile note with some of those specifics to clarify that the reaction isn't a true allergy. Another type of reaction that can occur that is not a true allergy is what is considered a pseudo-allergy. And it's called that because the symptoms of this type of reaction may resemble a true allergy, such as flushing, itching, sweating. Hives can also happen with true allergies and with pseudo-allergies, so these can be a little tricky. Hives are those raised, well-defined area that are often red and itchy. But with pseudo-allergy, patients usually have milder hives that are not associated with more severe reactions such as difficulty breathing. So in these types of cases where it may be a pseudo-allergy, the reaction is often caused by a direct histamine release due to opioids. And that histamine is released from those certain types of cells called mast cells, but it's not an immune-mediated response and not a true allergy. Most of these pseudo-allergies involve codeine, morphine, or meperidine. So that could be the situation with our case. Perhaps the patient had flushing, but not a true allergy to morphine. So you might need to do more investigation to find out what the reaction was. But pseudo-allergy doesn't always mean you must avoid the opioid. There are some strategies that can be tried to manage pseudo-allergy. And one thing to consider is that the risk of pseudo-allergy seems to depend on how much opioid is at those mast cells to stimulate that histamine release. And so that may vary with the opioid dose or with the potency or with how the opioid is given. So it makes sense that one option for pseudo-allergy is possibly a lower dose or to consider a different opioid. For example, some opioids, such as those that are more potent, may be less likely to cause histamine release. But if the opioid or dose can't be changed, another option is to suggest pre-treating with an antihistamine, such as cetirizine, and possibly adding an H2 blocker, such as famotidine. That would more completely block that histamine reaction in that pseudo-allergy reaction the patient is having. But we also want to really be sure to listen for patients reporting those more severe symptoms. So those can be signs of a true allergy, which is an immune-mediated reaction. So be alert for patients who report issues such as shortness of breath or bronchospasm due to an opioid or severely low blood pressure, swelling of the lips, face, mouth, for example, which is sometimes called angioedema, or more severe skin reactions or other types of rashes. Hives, once again, are a little tricky. They can also be seen with true allergy or pseudo-allergy. But that's why we want to ask how severe the hives were and whether the patient had any of these other symptoms. And in our case with that allergy alert, if the patient reports that they had these types of reactions, it's usually prudent to assume that it was likely a true immune mediated allergic reaction. And that's why careful questioning of the patient is so important. But with a true allergy, it's also important to note that pretreatment is not an effective option, and we likely need to think about a different med choice here. So hopefully those non-drug measures and non-opioids such as NSAIDs or acetaminophen have been tried and optimized already. And if an opioid is still needed, we'll need to suggest an opioid from a different structural class, along with very close monitoring, even though this cross-reactivity is rare. So let's look at the four major structural opioid classes. On the left in the dark blue, we have the morphine-like or phenanthrenes. And these obviously include morphine, but also codeine, hydrocodone, hydromorphone, oxycodone, and others. Then in green, we have the phenylpiperdines, which include fentanyl and meperidine. In the purple, we have the diphenylheptanes, which includes methadone. It's structurally unique in this class. And then on the far right, in the bright blue, there's the phenylpropylamine group, which includes tramadol and tapentadol or Nucynta, which are structurally similar to each other. So for example, for a patient with a true allergy to a drug in the morphine-like class, like in our case, where the alert came up with morphine when that oxycodone prescription was entered, an opioid from a different structural class may be an option, such as tramadol, which is a phenylpropylamine, along with that close monitoring, of course. So I think based on all of this, it's easy to see why it's important for us to take steps to avoid labeling non-allergic patients as allergic, since those true allergies are rare, and accurate documentation is important. Not only to ensure that opioid is avoided if the patient has a true allergy, but also to ensure that treatment isn't delayed or withheld unnecessarily if it's not a true allergy. So we want to be sure to clarify the type of reaction the patient had when we get those computer alerts, or just, routinely when updating patient profiles or asking about allergies. We also want to ensure everyone in your pharmacy is working as a team to document things clearly and specifically. So for example, just including the reaction, the specific symptoms, the specific drug name, along with the opioids the patient can tolerate can be helpful. And then also in the event that the patient did have a true allergic reaction, we want to help ensure that it gets documented correctly and that the opioid that caused the reaction gets discontinued to prevent any future filling of that med. So see our resource, Opioid Allergy. It includes an algorithm to help decide the best options for patients. And then there's also an FAQ chart for more details about opioid allergies and intolerances. Now we'll close things out with a spotlight on natural medicines. And today we're going to take a closer look at echinacea, a product I'm sure patients have asked about a time or two, especially recently. Our article reads, cold and flu season will bring up questions about echinacea for respiratory infections and other uses. So let's dive into what we need to consider about echinacea's efficacy and safety. Let's put on our botanist hats for a moment. Some of you may recognize this very pretty flower as echinacea, but did you know it's closely related to ragweed and sunflowers? These are all members of the Asteraceae family, which includes chrysanthemums, marigolds, daisies, sunflowers, and ragweed. Certain species are used medicinally and seem to have anti-inflammatory, antiviral, and immunostimulant effects. So this has led to the interest for the treatment of a myriad of conditions such as COVID-19, influenza, and the common cold. In fact, echinacea is possibly effective for preventing the common cold. A pooled analysis of studies suggests that echinacea may reduce the risk of developing a cold by 10 to 58%. But keep in mind a couple of things. Not all of the studies showed this benefit, and it has only been effective at preventing the common cold, not treating it once a patient already has a cold. And on the other hand, there just is not enough evidence to say if echinacea is helpful for many other conditions. And these include COVID-19, the flu, middle ear infections or otitis media, tonsillitis, and others, things that it's been looked at or studied for, but hasn't really shown to be effective are anxiety, cold sores, migraines, warts. There's just not enough evidence for any of those indications. So that's a quick overview of efficacy. Let's move on to safety. We can clarify that oral echinacea is generally well tolerated. Some of the side effects reported include GI effects like nausea and stomach upset. Itching and rashes may also occur with echinacea. I did mention earlier it's closely related to ragweed. So patients who are sensitive to ragweed or mums or marigolds may be at a higher risk for allergic reactions or sensitivities to echinacea. According to certain studies, this seemed to happen more in children than adults and in patients with a genetic tendency towards allergies. So that's something just to kind of keep in mind. Also be aware that while it's uncommon, cases of echinacea-induced hepatitis or liver damage are reported, but full recovery from these cases have been reported. And if asked about using echinacea in pregnancy, explain that it's possibly safe when taken orally for up to 7 days based on very limited evidence, but there's really not enough evidence to say whether it's safe in breastfeeding. Another good point to keep in mind is there are no known major interactions with echinacea. There are some situations in which we might want to be more cautious. So if patients want to take echinacea, we should definitely ask about current meds or medical conditions. For example, echinacea might inhibit the metabolism of cytochrome P450-1A2. So we'd want to just advise caution in patients on meds metabolized by CYP1A2, such as clozapine. And it has been shown to increase or decrease the level of drugs metabolized by cytochrome P450-3A4 drugs. So take care with patients who take meds like apixaban or other CYP3A4 drugs. Also caution against echinacea for patients taking immunosuppressants or for those with autoimmune disease, such as multiple sclerosis or rheumatoid arthritis. Echinacea can stimulate immune function, and so that's important to keep in mind as well. So that was a quick high-level overview of echinacea. Let's just discuss a little bit more about its use for cold prevention, since it's the one area with some evidence. Echinacea does not seem to have a significant benefit for treating colds that have already developed, so that's important to keep in mind. If patients want to take echinacea for cold prevention while they're still healthy, suggest trying one of the commonly studied doses, which is 300 milligrams 3 times a day for 7 to 14 days. Point out that in some of the small studies, it was also continued if folks got a cold and taken for 5 to 7 days after an infection. It's also important to note that there are limited data in children, so there's no recommended quote-unquote typical dose that we would advise using. So let's just wrap up with a few practice pearls for echinacea. If patients ask about echinacea, be sure to ask them if they have any allergies or sensitivities to flowers, and caution them of a possible higher risk of allergic reaction to echinacea if they do have those sensitivities to mums or marigolds or ragweed. That's a key thing to point out with this supplement. In fact, the Medicines and Healthcare Products Regulatory Agency in the UK recommends against the use of oral echinacea products in children under the age of 12 due to this risk of allergic reaction. So it's very important just to warn patients and parents about this. And as with all the other supplements, continue to educate that natural doesn't mean risk-free, and some products may contain contaminants. So try to guide patients towards products that are certified by a reputable third party to help ensure they get the quality product and it has the labeled ingredients and doesn't have those harmful levels of contaminants in it. For more specifics on echinacea, you can review its complete monograph in NatMed Pro, which is our comprehensive resource for natural medicines and complementary therapies. It has much more guidance on dosing, efficacy, and interactions, and does provide some specifics on the dosing that has been used in children for different products. And now it's time for our polls and questions portion of the program. This is the time when we get a chance to hear and see what you're doing in practice with our polls. And we also get a chance to answer some of those great comments and questions you've been sending in throughout the presentation.
Thanks, Sarah. I'm Kat Samai, an editor with Pharmacist Letter, and I've been chatting back answers to your questions along with some of our other editors. And Jeff Langford is going to join us to talk about some of the questions and comments you send in. But first, Jeff, do you want to launch a poll question?
Sure thing, Kat. I'm sending one out now, and we can dive right into some of the questions the audience had for us this evening.
Awesome. There were so many. Let's kick it off with something about Paxlovid. Why is Paxlovid preferred over molnupiravir?
Okay, yeah, a good question because that is both are considered options, but Paxlovid is definitely the preferred choice of these two. We do have data that it reduces risk of hospitalization and mortality in high-risk patients who have mild to moderate COVID-19. So we have evidence of benefit there. Molnupiravir's evidence is more limited, showing that it reduces time to recovery, but we don't have evidence that it reduces hospitalization or death related to COVID-19. So for that reason, Paxlovid would come out on top and be our preferred choice for outpatient treatment.
Great points.
Yeah, and our question is focusing in this area, asking about the maximum number of days from symptom onset that an outpatient may be eligible for treatment with a COVID-19 antiviral. And I'm going to share the results with the audience, but the correct choice was B, and most of our audience did pick that. Treatment must be started as soon as possible, and that's going to be within 7 days of symptom onset for IV remdesivir, or within 5 days of symptom onset with Paxlovid. If those drugs are not options and we would consider molnupiravir, that's going to be a last resort. It can be started within 5 days of symptom onset. Okay, second poll question going out, Kat. What else do you have in your list of questions for us?
Okay, let's take a look here. All right. Is RSV an annual vaccine or just once?
Okay, too soon to say, I think, is probably the fair answer. Right now, there's not a recommendation to repeat it, and RSV vaccines do appear to provide some protection for at least 2 seasons. Of course, there additional data is being collected and other studies are being done to assess really how long these vaccines protect, and if other doses will be needed. That recommendation may evolve over time. So I think we're still learning about that. But right now, we wouldn't recommend a repeat vaccine. At this point, we do have preliminary data to suggest they provide protection for at least 2 seasons. I'm going to shift here, Kat, to a different topic. Our poll question was asking which opioid is structurally similar to morphine. I'm sending the results out to everyone to take a look at, the correct answer being choice A, codeine. We can think of those 4 major structural classes that Sarah discussed when we consider opioid drugs. We have the morphine-like opioids, including drugs like hydrocodone and oxycodone. Tramadol and tapentadol are structurally similar to each other. Fentanyl and meperidine are structurally similar. And then methadone we can think of as being structurally unique. And I'm sending the last poll question out to everyone, and let's tackle one more question before we close things out, Kat.
Sounds good. And the vaccine questions were really hot tonight, so I have one more.
All right.
Can vaccine be injected in an arm that has a freestyle sensor?
Okay. Practical question, especially as these CGMs kind of take off and more patients are using them. And as you might expect, there's not specific guidance on this, but in general, most experts say it's fine. Keep in mind that the Freestyle Libre sensor is applied to the back of the arm, and our IAM vaccines, of course, given in a different site. But if a patient does present and we cannot use the other arm, or they want to get it in the same arm for whatever reason, expert opinion says it's okay to do that. And our last poll question was asking about safety concerns with oral echinacea and what is a reported safety concern. Correct answer was choice C, hepatitis. I'm sending that out to everyone to take a look at. Most common adverse reactions are going to include GI side effects like nausea and vomiting, or skin reactions like a rash. But we do have allergic reactions that are reported. Certain patients may be more sensitive, those that have other atopic issues, or those that have allergies to ragweed or plants. And we do need to keep in mind, although it's not common, there are cases of echinacea-induced hepatitis that have been reported. All right, Kat, well, we covered a lot of territory pretty quickly here. I'm going to turn things back over to you to get the CE code and all those instructions out to everyone. And thanks so much for your help with these questions.
Of course, thanks. To you too. All right, here we go. What everyone's been waiting for. This is the final page with our CE credit and instructions for today's program. As a reminder, the quiz password for today's presentation is 6636. You'll need this password to complete the course evaluation and quiz to get your CE credit. Again, today's quiz password is 6636. You can follow the instructions in an email that we'll send to you in about an hour to log into the course page. Click on the Take Quiz link and enter the quiz password to take the quiz and get your CE credit. Please remember that you must complete the quiz within 30 days in order to receive CE credit. And be sure you've added your correct NABPE profile ID number and date of birth to your account with us. Check that your completed courses are showing up in CPE Monitor, usually about a week after you submit the quiz. If you gave us accurate information and don't see your credit in CPE Monitor, please contact us right away or you may not be able to receive credit. And if you'll be joining us for the next session, I encourage you to complete the quiz later so you do not miss the beginning of the next session. The December forum will start at the top of the hour. To join us for this next session, you'll need to exit out of this webinar and enter the next webinar using the link in the confirmation email for the next session. Thanks, everyone, and thanks, Jeff.